Thank you, everyone. I have the pleasure of introducing our next speaker, Dr. Melissa Abel. She is a co-chief fellow hematology oncology at the National Institutes of Health. Thank you.
Is everything do I need to do anything with the slides? The clicker's here. There we go. Okay, that's up. All right. Hi, everyone. I know it's been a long 2 days. I'm Melissa. Thank you so much for having me. I'm really honored to be here with so many of these other speakers that I've been kind of watching throughout my training and learning from and collaborating with. And so it's really, I'm really excited to be here. And I've learned so much from the talks that I've been fortunate to come to as well. So it's been great. So I'm not going to get really in the weeds of all the research because you guys have heard so many presentations, I think, that have talked about a lot of the big concepts in research in small cell right now. So what I'm going to try to focus on is just to kind of go through the big picture philosophy of what we do at the NIH and kind of what we think the approach to lung cancer research should be in general. And the kind of take-home message is that we're really focusing on finding new treatments for small cell lung cancer, one patient at a time. And we really believe that you can learn something from every single patient, and that every patient that we see, we can, as much as we can learn to help future patients from that patient, is really the goal. I'll briefly talk through a few specific areas of research that are unique to our group. We do a lot of kind of similar things to what a lot of people are doing, or at least in the same vein. So I'm not going to repeat all of those concepts, but we'll go through. So I work with Dr. Anish Thomas. He runs the small cell lung cancer research program at the NIH. Our group only sees small cell. So we see, sometimes in our phase 1 trials, we'll see other cancers as well if it's not specific, but we're very small cell focused. We also see small cell cancers of other organs. So we're seeing these days a lot of small cell prostate, but we've seen small cell from pretty much every organ you can imagine. And those patients are treated like small cell lung. So that's kind of the space that we're working in. And we work with, Dr. Thomas has a whole lab with scientists, grad students, and that whole bit, and then also a clinical team. And so the space we're really focused on is actually how to translate like what's going on in the lab to patients, and that kind of in-between space, and how do we bridge that together. So I'll briefly just explain what the NIH is, and I'm sure some of you guys, I think, were there during my talk when I did a virtual talk, so this is a repeat, and I apologize. But for those who weren't there, I didn't really know what the NIH, I didn't really understand that it was its own hospital until I was probably in residency or something. The NIH is a government organization, the National Institutes of Health, that funds a lot of research. And the NIH external portion gives out grants to researchers around the country and even around the world based on grants that they write, and is like the primary funder of research. And so I think from an advocacy standpoint, like these, there have been a lot of sort of decreased, budget cuts to the NIH that have, I think, are going to in the future affect the amount of available money that there is out there for cancer research, unfortunately. So, but the NIH also includes the NIH hospital, and we call it the clinical center, where everything that we do is for clinical research purposes. So it's not like a standard hospital with an ER where people come in and get treated for like their heart attack or whatever. Like there's another hospital right across the street where we do that. But at the NIH, every patient that comes is on some kind of clinical trial. And a lot of the focus also is on treating things that are rarer and maybe don't have good funding because it's higher risk, higher reward research. And so like from a financial standpoint, and so we try to really fund that through the government and enable researchers to dig into these bigger questions. So it's the world's largest hospital devoted entirely to research. Some basic info about it. I'm just going to skip ahead really quick. And so as I mentioned, all patients are enrolled on clinical trials. So we talked about community practice. We're on like the complete opposite end where everything is research, very academic, but we do collaborate really, really closely with our patients' community doctors. And there are truly some amazing community doctors out there that we work with and are emailing and texting and kind of collaborating on taking care of patients together. And that's how a lot of our patients find us. Their community doctor finds our trial and reaches out to us, and that's wonderful. So the different types of studies that we have include one just natural history. So there's no actual treatment involved, but patients can enroll, especially for rarer diseases where we're just trying to learn about the disease. And so even if patients don't live nearby, they can enroll and we can get, it basically gives us consent to get access to biopsy specimens, get some blood draws for genetic testing, and then we check in every 6 months with the patient and see how they're doing and kind of learn about the course of the disease. And this just basically expands the research pool of what we can learn from and the number of patients we can learn from. There's occasionally standard of care, meaning FDA-approved treatments. We don't do that too much for small cell, especially not for first-line treatment, because it's so, with the radiation and everything, for limited stage, you really need to be nearby your own home. But for the most part, what we do is either a standard of care plus an investigational agent or an investigational agent alone. And the investigational agent may mean a completely first-in-human, brand new treatment that's kind of coming out of the lab, or something that has already been tried in a different setting or not with that combination, but it's a new combination or a new indication that we're using the drug for. So just getting back really quick. If you guys have heard a lot about clinical trials here, and I think the big takeaway that, you guys are all really savvy and connected with, and clearly are good advocates for yourself. A lot of patients don't know about clinical trials, don't have access to clinical trials. And for diseases like small cell, where, for metastatic small cell, the treatment options, we want more from what's there, right? And so this is an example of the NCCN guidelines, which is like what oncologists use to go through and make sure that they're following the exact guidelines. It's for pancreas cancer, but the same thing applies, where you actually see that clinical trial preferred is like a first-line option. So it isn't something that you wait to do until there's nothing else left. Like at any point in time, clinical trial is a great idea because we're not satisfied with the treatments that are currently there. Although there are obviously some excellent responders, but it's usually the minority. Okay, so the big challenge with small cell in terms of finding new treatments, because I think that's what we need. We can try to reuse all these old chemos and things, and we kind of know that this isn't giving us what we want. And so we're really trying to create completely new ways of treating small cell. There's so many exciting things coming down the pipeline that I think y'all have heard about, between tarlatamab, all the DLL3 treatments, new antibody drug conjugates, and they at some of the recent meetings, they were really showing a lot of promise, and I think it's going to be really exciting. But up until recent years, very, very little was known about the actual molecular biology of small cell. And one of the big reasons is that there aren't that many clinical samples available. So with non-small cell, they get surgery. We have these giant tumors that, and there's thousands and thousands of patients, and everyone can kind of learn from these samples. But with small cell, as you all probably know too well, you get a very small biopsy. Sometimes it's just the aspiration, and you just get a few cells, and that's enough to diagnose small cell. But it's really limits how much we can study the disease. And then most patients don't get surgery, and most patients never get biopsied again. And so we know what the disease might look like at diagnosis, but once it becomes chemo-resistant, it's a completely different disease. And so, the struggle in the past has been we didn't have any tumors to actually look at and study. And this is reflected in, these are two big cancer DNA databases that researchers can use, where again, there's 33 and 38 different cancers, 11,000 tumors in the Cancer Genome Atlas. And these are, available to anyone that wants to go. They have the whole genomes of all these tumors that they've collected over years and years, and there's no small cell at all in the TCGA or in the pan-cancer analysis. And that's the reason, because, they're not getting these surgical specimens that they're automatically sending off for sequencing. And so as a result, historically, most of our knowledge has really been from cell cultures and mouse models, which, from the talks yesterday, I know with Dr. Oliver's lab and everything, you'll know that there's a huge benefit. I mean, these are crucial to our research and our understanding. But if that's all we have, then we're kind of, we're really learning how to cure mouse cancer or how to kill cancer cells in a petri dish, which we know doesn't always translate to actual patients. And so it really needs to be a mix of both. We need to be learning from patients, we need to be learning from the actual patient tumors, and then using these lab techniques to kind of validate our findings and learn more about how to create new therapies. And so this, in 2012, there was an act passed by Congress called the Recalcitrant Cancer Research Act that required the NCI to develop specific frameworks for treating particularly hard to treat cancers. And as a result of that, the small cell lung cancer program was born. Dr. Thomas has been there from kind of near the beginning. There's a lot of kind of historic small cell research at the NIH. And then for the past almost 10 years, Dr. Thomas has been heading this up. There's been over 15 clinical trials, 7 investigational new drugs, and I think probably at this point over 500 patients enrolled, over 250 research biopsies, and at least 18 small cell lung cancer research autopsies that we have done. And the idea is that, it's really, the research should originally start with the patients. Like that's where we should be starting. That should be the center of the focus of our research. And then we should be branching from there. And that even small trials and even one single patient can still provide so much information that can teach us about this disease. And so the priorities of our team are first off to give the best possible care for every patient, both in terms of what we're giving them and also how we're treating them, how we're communicating, which I think has come up as well. I think we're in a little bit of a bubble because we don't have as high of patient volumes as a lot of places do, where we can, and we have these research nurses who are amazing and like text with our patients. And even when they go off trial, we're still getting pictures of updates of what they're doing and all of that. And I don't think every cancer center has the luxury to do that just because of the volume of patients that they have. But like we email with our patients, it's really, and really kind of, I think become some of our patients become a part of their family in like a way. So I think number one is excellent treatment, excellent like patient care and patient relationships. And then 2 is trying to learn as much as we possibly can from every patient. So again, just briefly go through a few areas of research that are specific to our group. The first one is something called replication stress, which is a thing that's unique to small cell cancers. And as we've all talked about in these earlier presentations, we know that there's differences in different patients with small cell lung cancer. Not everyone is the same, but everyone still gets treated the same, and outcomes haven't improved in in decades. One thing that is unique about small cell compared to normal cells in the body and other cancers is that it accumulates really high amounts of DNA abnormalities and mutations as it's dividing. It's so fast growing and dividing, and the DNA is just very messed up. As a result, it really has to fix itself in order to keep growing. And so one protein that our lab was able to kind of show is really important for this in small cells, something called ATR. It helps the DNA fix itself while it's dividing so that the cells can keep on growing despite having really abnormal DNA. And so our group has investigated this more and found that patients with the higher neuroendocrine genes, which is the ASCL1 NeuroD1 that we've been talking about, tend to have these really high replication stress profiles. And patients with the non-neuroendocrine or the more inflamed subtypes have lower replication stress but are more sensitive to immunotherapy. And so the idea being, there's differences that can also predict drug responses. So how can we better figure out who benefits from immunotherapy and who might benefit from DNA repair targeted agents? And, all of these papers, there's 7 papers listed there, and all this data, has come from small trials. Like these are trials with 10, 12 patients, and a few of them are bigger trials, but even small trials that even if the drug doesn't get FDA approved can lead to really big discoveries that create benefit for the future. I'm just going to go through this quickly, but these are different trials that we've done in this DNA repair space using inhibitors of ATR, one in particular called berzosertib. This was actually the first ATR trial. Now there's multiple out there, multiple different ATR inhibitors in trials. And one trial we now have is a randomized trial in second line with berzosertib, the ATR inhibitor, plus topotecan versus topotecan alone, and has shown a survival benefit so far. The kind of where we're at right now in the clinic, And again, this is one small area of our research. We also have immunotherapy trial. Like we have multiple different trials coming down the pipeline in different spaces. But right now we have a trial with an ADC combining with berzosertib so that we can try to create a more targeted and less toxic chemo approach to go in, damage the DNA of the cancer cells, and then inhibit their ability to repair themselves with the ATR inhibitor. And then this is one patient's PET scan down here who responded nicely during our phase 1 trial. And you can see in the PET scan there's still black spots, but there's far more black spots in the before picture than the after picture. And this patient responded for quite a long time. And I think he actually had small cell of the prostate, but I think he would cater well to the LiveLung philosophy because he was someone who very much lived his life. Like cancer did not define him. It was a thing that he had, and he was like outliving his life. And he had some crazy story every time he came back to clinic of some wild thing he was doing. So I think he would really love that. I won't give any info about him, obviously, but he would love that his picture's being shown. And so the future plan is, again, to kind of create and validate new antibody-drug conjugates, new immunotherapies and BiTEs and all of that to try to create more tolerable combination therapies for second line for chemo-refractory small cell. All right, so then the next area I wanted to talk about is looking at tumor heterogeneity. So this is something everyone's talked about. And ultimately, when people ask, why can't we cure cancer? This is one of the major reasons. So if this is a tumor, pretend it's like a gumball machine kind of situation where, there's the blue cancer cells and the red ones and the yellow ones. And maybe the red and yellow are really chemosensitive. So you give that first line chemo, it kills all those cells, the tumor shrinks, everything's great. But then these chemo-resistant blue cells that are staying back behind grow out, and at that point, it's become very hard to treat. And that's why using a lot of these targeted therapies is also hard because there's some cells that don't have the target, and they will just kind of, like natural selection, they'll grow out. And so, because of this issue with very few biopsies, this isn't really well understood in small cell. It's becoming more so. But this is a big thing where we've tried to look at how does this heterogeneity contribute to treatment failures and how can we overcome that with new treatments. And then additionally, tumors can be different throughout the body. Again, a biopsy is usually just one small area. And so we have done a lot with research biopsies. So when patients come, many of our patients are generous enough to undergo an additional biopsy for research purposes. We only do it if it's something that's really safe and accessible, like a lymph node or sometimes the liver. We're not doing any invasive procedures to get them. But that way we can see what does this disease look like once it's already become resistant to first-line chemotherapy. In addition to that, we also have patients who've enrolled on our rapid autopsy study, where after they were, toward the end of life, they actually came to the NIH for end-of-life care. And then after they pass within 2 hours, we do an autopsy where we actually basically do a surgery and resect out the tumor. And that way we have all this tumor that we can look at and how it's different throughout the body. And that can give us so much information. And it's really such a gift and something that I was a little nervous about it when I joined the group because it just seemed really morbid and like a difficult thing to talk about. But our patients who've done it are so passionate about doing it. They often express that they really feel fulfilled. It's like something that gives them kind of hope, even though they're at the end of their life. And we're still in contact with most of the families of the patients who did this, and we like to send them updates whenever we have new research that comes out or a new trial that comes out as a result of what we learned from their loved ones' autopsy study. So it's not for everyone, but it's really been a huge gift from a lot of our patients and who I think we're really proud. We had a patient recently who put it in he wrote his own obituary, but he put in that he was the first patient on a first in human trial. And then he also participated in this, it was a big chunk of his, he was so proud. And again, we try to learn as much as we possibly can from each of these gifts that we get. So I just wanted to go through how we can learn from every single patient. This is a patient that we've probably learned the most of because it's a patient who had an autopsy many years ago. We can also get a lot of this information from biopsy. So this is not all autopsy. Very similar information can be gotten from a lot of our patients who get biopsies and are still like long-term responders and are outliving their lives. But this patient in particular, we just learned so much from. They did an autopsy. Well, we also treated him on trial. So we had like blood to look at blood biomarkers throughout his course. We looked at how he responded to different therapies and all of that as well. And then during autopsy, we were able to get cells from lymph nodes, lung, liver, and the adrenal gland, and able to do sequencing and all these studies on these cells, and then also make cell lines that we're still using in the lab years later, and that we've shared with collaborators as well. And so a lot of what we're looking at is, why does this cancer like to go to the brain? Why does it like to go to the liver so much? When it gets to those areas, that's when it becomes really hard to treat. And why is that? What's unique about those metastatic sites? And so having these cells from different areas has really broadened what we're able to look at in the lab. So I'm not going to go into this, but this is a paper that was basically centered just on this one patient, learning about a specific DNA abnormality that is in small cell that we are then able to see in other patients as well, but we found in this one patient. And it, was this large paper that was published in Cancer Discovery, which is it's a pretty big journal. And this is all, again, from what we've learned from one single patient, but confirmed in other patients as well. We've done single cell sequencing epigenetic studies, and those results have led to a new clinical trial that we're doing right now that's multi-center with topotecan, pembrolizumab, and tazemetostat, which is a drug that affects how the DNA folds on itself in a way. And then also looking at spatial tumor analysis. So are the immune cells, why aren't they getting into the tumor? Are they on the outside of the tumor? Are they not there at all? And actually being able to look at a picture of the tumor and see how the cells are oriented can provide us, I think, a lot of information that at this point we're doing the magic portion where the bioinformaticians are interpreting this data. So I don't have results of it yet, or for the most part, but to me, it is also magic, so it's ongoing. These are our currently open trials. Again, we have multiple that are coming down the pipeline, but are in their various levels of bureaucracy, as is the nature of clinical trials. So then just to kind of get back to our key point, which is this paper that was published in 2008 called Crossing the Valley of Death, and it basically looked at how there's this major gap between what's happening in the lab and what's actually happening for patients, and they kind of called that the Valley of Death. It's like they're doing all this research and all this funding, but the patients aren't getting the effect that we want from that. And that's always going to be the nature of research to some extent. You have to try thousands of things for one thing to work, but Dr. Thomas and our former fellow, Dr. Desai, wrote a paper called Translational Research, a Patient-Centered Approach to Bridge the Valley of Death, that kind of highlights this philosophy of how, the key is to always bring it back to the patient, always start with the patient, do stuff in the lab, and then bring it back to the patient. And that's really where our ideas should be starting and what should be forming our new treatment approaches. And so hopefully, this is our team. I'll say really quick, first off, again, our patients are so dedicated. Any of you all have been involved in a clinical trial know that, it's a huge commitment. It's not only a commitment to give a bunch more blood and extra biopsies sometimes, but just time that you're at the doctor. You're there for way longer. And a lot of our patients travel. I will mention the NIH, we don't take insurance. Everything is free for patients. Including the airfare for the patients, and there's a stipend for a hotel for at least most of the cost. And so we are able to get patients from all over the country, but it's still, they still have to fly then to come see us. And so it's a huge, huge commitment for our patients, and a lot of them are really dedicated to being a part of research. So without them, we wouldn't have any of the information that any of us do for any of our research. Our research nurses and the rest of our team is all here. Dr. Desai on the left is now at Fox Chase. He's a thoracic oncologist. So if you're in Philly, you can go see him. And then of course, a lot of people have talked about collaboration. I think in the small cell world, everyone is so collaborative. We have regular meetings, all together, and everyone shares information freely because it really is we're all here trying to get to the same end of this really, really difficult to treat disease. And so I've really enjoyed being a part of that as I've stepped into the small cell world. And I will also say, on another hopeful note, as probably the most junior person who has presented today in academia, we have so there's this small cell lung cancer research consortium where we all get together and talk about just lab stuff basically. And then they recently made a subset of it for young investigators. So it's all grad students, postdocs, and fellows and very early career investigators to kind of have their own space to share ideas. And so we had a virtual meeting, and I thought it was going to be probably 25 people because I kind of know the few other fellows and grad students that do small cell. It seems like a kind of a tiny world. There was 150 people at this virtual meeting, and we're doing it, at least once a month from all over the world, in Europe and in Asia. There's people from everywhere, and I signed on, and I was stunned. So I think historically from what I've heard, historically, small cell was an area where people kind of it's going to be really hard to ever have success in that field. That's not really, it's not worth doing research. It's so difficult to do anything, right? There's nothing there. And I think now there's, so many people studying this disease that it makes me really hopeful for the future. So that's all I got.
My brain again, I just thought of something I'd like to make your slide as we're talking today. We know that, it responds well to chemotherapy at first, small cell.
Yeah.
But then, the resistance and things come. What causes it to respond well? Do we know what causes it to respond well to chemotherapy?
Yeah, to some extent, that DNA instability that it has is a big part of it. Because when the DNA is already kind of messed up and it's quickly dividing cancers in general tend to respond faster to chemotherapy in general because chemotherapy inhibits the DNA replication. And so fast dividing cancers, the DNA is dividing fast, chemo damages that, they die, whereas the slower growing tumors, it can be more difficult. So that's a big part of it. I think we understand why cancers are chemosensitive. We're just, I think, still really learning about what makes them chemo-resistant and what to do once they're chemo-resistant. Yeah.
Dr. Abel, I've been in remission for over 5 years, but that's remission. So my 8-point-something centimeter tumor has stayed at 2-something for 5 years. But I am so interested in end of life and rapid autopsy. I need to know how I set that up.
Yeah. So we've had patients, I will say if there's no disease, if you have no tumor, I don't know if you'll qualify. I will say that for our particular study. And there are other places that do them as well. But if anyone is interested, I don't know if my info's on here, but there's an NIH referrals office. I think it's just NIH or NCI refer. I'll send it to these guys and they can forward it. Okay. So we've had patients come from other states who really were dedicated. Usually it's patients that were on one of our earlier studies, but we've had patients who contacted us and said, I'm really interested in this. It's something I'm really passionate about. I live in the Midwest. I'm getting my treatment with my local oncologist, but in the future, this is something I'm interested in. And then, as they kind of were on hospice at home and then got closer to end of life, then they ended up, with their family coming out and coming to the NIH towards the end of life. So
I just wanted to repeat something that you said because I just want to make sure everyone heard it because she kind of said it like it's not a big deal, but it's a huge deal, is that all the clinical trials at the NIH are free to the patient. So that is wonderful. I just also wanted to ask you a question, kind of a double question, actually. With the Recalcitrant Cancer Act that was passed, was there funding attached to that? And the other part, or different, but funding question is, under the congressionally directed medical research program, the lung cancer research program, does the NIH receive any of that fund, or is that something separate?
So to the first question, there was funding. I don't know the details of the funding. If Dr. Thomas was here, he would definitely know. It was just so far before I got there. For the second question, I don't think the NIH isn't eligible to get certain types of funding because of the other funding we get, if that makes sense. Like we're in a very separate funding bucket, as you may know.
That's good.
Yes, yeah. The only two malignancies that were named in that 2012 Recalcitrant Act were pancreatic cancer and small cell lung cancer. And it was a 10-year, and there's many UO1s that are associated with it. And that's where the small cell consortium from all the big players was created, and that still is ongoing. I think it was a 10-year program, and so I think they reevaluated, and I think that it's no longer deemed a recalcitrant malignancy, which is a victory for small cell, and we should obviously celebrate that. But it has generated a lot of the excitement that we see in the funding and the research that has led to all these breakthroughs. So I think that we owe that, just as much to everything we're seeing today. So that's why all this is kickstarted. Is really the second golden age of small cell is what it's known as for small cell research. So absolutely.
Yeah, if you look at the past 10 years of like what we knew 10 years ago and what we know now, it's truly remarkable. And so I think that is probably reflective of that funding.
I just want to jump in here. Yesterday, we saw the acknowledgments from Dr. Oliver's lab, and I'm trying to think of. Sorry, it's been a long 2 days, but yesterday it seemed like most of the researchers who showed us their acknowledgments. And Dusty, I'm going to let you jump in because you are far more knowledgeable about this. And everyone in this room, you need to understand where lung cancer research funding comes from. And one of the most important is from that Department of Defense. What is it, the National? I'll let you take over from here, Dusty.
Yeah, the CDMRP, the Congressionally Directed Medical Research Program, and then under that, the Lung Cancer Research Program. This year, it's funded at $25 million level, which is the highest it's ever been funded at. It was started in 2009 at 20 million, and then it just went down, down, down. And when you take into consideration inflation, we're still underwater with that fund, but we are up to 25 million. And I would say that last year when they increased it to 25 million, we were the only cancer under the CDMRP that did get an increase. So it went from 20 to 25. And so that's good. But you're going to get emails from us occasionally, and we're encouraging you very strongly to email, and we make it easy. We've got a platform. You just click, 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 and you've emailed to your senators and your representative. But there are also, ways that you can do it. Ask your friends, ask your family. Share it on social media because it is highly impactful. And the government funding of cancer research is the biggest funder of cancer research.
Yes.
Correct?
Yeah.
Sorry.
Yeah, no, I mean, this is not my area of expertise per se, but I mean, just as someone who's like a young investigator trying to kind of start applying for grants and getting my career off the ground, the biggest issue is funding. Like this is why people leave research. Is because it's so hard to get funding for your research ideas, and it's becoming harder and harder to some extent. And lung cancer particularly, I mean, as you guys know, is underfunded for the number of patients that have it. I know for my colleagues who are going into breast oncology, there's like a million different funding sources they can apply to get funding for their projects, including all these private funds, and then also, ACR and ASCO and all these other organizations that have these specific ones because there's so much breast cancer fundraising. And then with lung cancer, there's not very many. There's like very, very few funding opportunities for like young investigators. I can only speak for as like a young investigator, but it probably reflects what it is like as a whole too. So there needs to definitely need more funding for research in lung.
If I could just call on Jim Baranski to just make a quick comment about what your organization does for young investigators and funding lung cancer research, Jim?
Sure. Good thing I wasn't eating one of those brownies just now. Don't look at how many calories are on these things. It's like, so Lung Cancer Foundation of America, our prime directive is to fund young investigators, which we've actually struggled with that name. Does the average person walking down the street know what a young investigator is? So we're kind of changing it to early career researchers. But so we're basically like a venture capital organization where we will invest $200,000 grants over 2 years to hopefully attract the best and brightest young minds away. And listen, all cancers are wicked bad, right? But selfishly, we're trying to attract these minds into the world of lung cancer. So yeah, that's what we do. And you are absolutely right. That is one of the greatest deal breakers for early career researcher or a young investigator is where am I going to get the dough? Because guess what? These institutions that they are at, pick your academic center, they don't like walk in there with a bag of dough for you. So
Yeah, just so you guys know too, for how it works for us, because I can only be an expert on my own experience, but that I can talk about. Most of the time for early career oncologists who want to do research, it's very difficult to get protected time for your research because the hospital systems need you to see as many patients as possible, which is important. It's not that that's not important, but if you're seeing patients 4 or 5 days a week, you don't have time to do any research. And so sometimes they'll give you some time at the beginning, but you're pretty quickly expected to bring in your own funding. You need to kind of justify, I'm going to have 2 days a week fewer of clinic because I have this money that I'm bringing into my own salary through my grant funding. And if you don't have that, they won't give it to you and you won't be able to do research essentially. So
Research is important, for
Jim
us
should have
and for
told
them.
them. Jim, you should have told them they know one. I mean, they have seen one of the people that you all have given that early investigator.
Christine Lovely. Some of you may or may not know Kelly Smith. Those are people who are in the world of small cells specifically. Yeah, for sure.
Any more questions? Thank you so much.